Hi, Dr. Matthew Weiner. I'm a bariatric surgeon located in Commerce, Michigan, which is just outside Detroit in southeastern Michigan. And I'm here to talk to you about and hopefully dispel some common myths about bariatric surgery. I perform primarily gastric bypass and sleeve gastrectomy procedures, and I really am deeply committed to not just the safety of the surgical procedure, but to preoperative and postoperative education and teaching of my patients. And I'm hoping that these videos can help them when they come into the office to make sure that they have a good understanding of what these procedures do and how they work, and dispel some of the urban lore that's out there about what you should or shouldn't do after surgery. So we're going to address about 8 different myths here. We're going to talk about stretching of your stomach or your pouch. We'll talk about carbonation, straws, extended release pills, soda pop and dumping syndrome, the timing of meals, eating and drinking at the same time, and what you should be eating. Most people think about protein first. So let's talk about myth number 1. You'll stretch your pouch or your sleeve out if you're not careful. And this is without question a myth and not how things actually happen. The reason that this myth exists is because when we started thinking about bariatric surgery, when we started doing these procedures, we attributed the weight loss success to anatomy. We thought that by making your stomach smaller or by rearranging the intestines so that you don't absorb as many calories, we call that malabsorption, we call making your stomach smaller restriction. Through restriction and malabsorption, we drive weight loss. And it's only these 2 factors that cause you to lose the weight. And so that when we look at failure after surgery, regain of weight after surgery, we go back to this anatomic description, we look at your stomach and the restriction or the malabsorption component and try to explain why this has happened from that perspective. But now, as I mentioned in many of our other videos, we have this other way that the surgery works, perhaps the most powerful and important way that works, which is through changing of your neurohormonal axis, meaning the hormones that circulate through your blood and through your body and also through your brain, and the nerves that fire and adjust our appetite and our metabolic rate. So what we find is that if you do endoscopies where we put a scope in through your mouth and look at the stomach, or upper GI studies where we can examine the size of the pouch, we find that there's absolutely no change in either the size of the pouch or the diameter of the opening in patients who are successful or unsuccessful years after surgery. And what instead is happening is that most patients, the vast majority of patients, have great success immediately after surgery. However, in the first year and in the second year, we see really great appetite control from the effects of the surgery. But this effect is short-lived. It is not lifelong in the vast majority of patients. And in fact, your appetites and your cravings and your hunger for processed foods will start to come back at year 2, at year 3, in some patients at 18 months or even a year after surgery. And in fact, success relies on you taking that first year, that first 2 years, where you're free from the cravings, free from the hunger for the processed food, and building healthy habits. You've dropped your weight significantly. You're now exercising on a regular basis. You're committed to health and fitness. And by changing your habits and looking at these processed foods as a potential source of addiction and craving, and eliminating them or minimizing them in your life, that you're able to succeed lifelong. And in fact, weight regain often has nothing at all to do with the stomach stretching or the diameter increasing, but rather it's a return of these addictions. It's a return to old habits. It's stopping exercising on a regular basis that drives the weight regain. And we have to look at this from a behavioral perspective and from a neurohormonal. And we also know that there's difference in genetics after surgery, that sometimes the surgery works better in some patients than others. That's very clear. There's even a gene that we can now mark to success after surgery. So there's a lot more going on than this just being a simple anatomic problem. And what proves this myth is untrue is the idea of narrowing the channel or placing a band around a bypass or doing something to try to shrink the stomach back down is totally ineffective in the long run for driving additional weight loss. And in fact, bariatric surgery, you have one shot and one shot only, in my opinion, to lose the weight and keep it off. So let's talk about myth number 2, and this really, I think, can be explained largely by our discussion about myth number 1 about avoiding carbonation. That's a very common discussion. Don't drink any carbonation, it'll stretch your stomach out. This is absolutely wholly untrue. First of all, the pressure in carbonation is very, very small compared to the pressure that we would be necessary to stretch the stomach out. So I have no problem with carbonation. The problem is that most things that are carbonated, diet pop, full sugar pop, some carbonated fruit beverages like, say, Orangina, are loaded with sugar. This is liquid sugar, the most potent weight-gaining agent on the planet, and they should be avoided for all of these other reasons. But if a patient came to me and said, I want to drink some Perrier or seltzer water or Pellegrino, a calorie-free carbonated water, I'd have absolutely no problem with any of my patients drinking that. It's not nearly enough pressure to stretch the pouch out. And even if it was, this isn't driving, the weight regain isn't driven by the stretch, it's driven by a return to old habits. So drink the healthy carbonated calorie-free beverages like Pellegrino, Perrier, and seltzer water. Another common question is no straws. And again, the origin of this is that either you're going to swallow too much air or drink too fast after surgery, and you'll stretch it out, or you'll cause vomiting or cause perforation, or whatever the myth that surrounds it is. But in my mind, when we talk about no straws, and we typically talk about this in the immediate postoperative period, in the first month or so after surgery, in the first days after surgery, what we're really doing is we're not emphasizing the important thing, which is to listen to your body immediately after surgery, that day 1, day 10, day 30, even the first 3 months. Things are very, very restricted. It's small amounts of even water can cause some chest tightness, some abdominal cramping as your body adjusts to this new anatomy. And there's some spasm that occurs that can make that even worse. And so when we talk about straws, what we're really doing is we're distracting ourselves from what is most important, which is that our body knows when it's too much. If you take a sip and it hurts, you've drank too much, or you drank too fast. If it's a food, it was too thick or tough of a food, or too large of a bite, or it wasn't chewed properly. And in fact, these are the factors that really that we should pay attention to, rather than whether or not you use a straw. So after surgery, pay attention, listen to your body. If it hurts, you're doing something wrong. If it goes down comfortably, it's a good choice for you at that point, provided it meets our nutritional rules as well. So immediate postoperative patients, if you want to drink with a straw, go for it. Extended release pills, another common myth, and a lot of my patients will come in on blood pressure pills that have an extended release capsule. In truth, you absolutely can take extended release pills. However, there's 2 components to that. First of all, extended release pills tend to be larger than regular pills. So oftentimes they exceed our M&M, regular size M&M pill size that we limit our patients to. So most extended release pills are too large and shouldn't be taken for bariatric patients for that reason. Secondly, extended release pills cannot be cut or broken up or opened up into applesauce, because instead of the extended release formulation, and this is a large dose, you'll get a very large dose and you can potentially overdose and drop your blood pressure, get sick, or have other problems related to that. So the issue with extended release is that you can't cut it and the pill size is typically too large. So rather than looking at just that component, we have to examine pill size, and we have to make sure that we only cut or crush or open up the pills that it's appropriate to. And in our practice, we have a pharmacist meet with the patients after their surgery and review their list of medications and let them know what they can open up and what they can't. And also, if we need to, we can adjust to a regular release pill and not use the extended release. But as far as the opening of the pill, because of the intestinal rearrangement from, say, a gastric bypass, that really isn't a significant issue. Dumping syndrome. Unfortunately, only around 10 to 15% of patients develop significant dumping syndrome. The vast majority of patients are able to tolerate liquid beverages without much difficulty. Now, dumping syndrome is intense abdominal pain, cramping, diarrhea, fever, and even low blood pressure that can be that can happen immediately after drinking a sugary liquid like soda pop. Now, it takes one single episode of dumping syndrome for a patient to say never again. It takes soda pop, which drives all these hedonic pleasure signals in our brain, and it basically turns it into an exquisitely painful and uncomfortable experience. I think that's great because I think soda pop is perhaps one of the worst foods on the planet for you. And if you're going to have any chance of succeeding after bariatric surgery, step number one is eliminate the soda pop, diet and regular, altogether. But the vast majority of patients initially can tolerate this if they so choose. Very few patients do so, and I think that's very wise. But it only affects us a very small amount. And even those patients who have dumping syndrome early on, 2 years out, 3 years out, there's going to be some modification of the intestine where it's going to become more tolerant to these sugary liquids. And in fact, the overwhelming majority of patients are able to drink sugary liquids without any discomfort, without any more discomfort than your average person when they're years out from surgery. Again, it's about making the choice not to drink these substances and recognizing that they will compromise everything that you've worked for and everything that you've gone through. So don't drink the pop, don't drink the juice, not because you can't, but because you decide not to. Myth number 6, you should eat small portions of food 5 times a day. In my opinion, I'm against regulating how frequently you eat or even how much you eat. What really matters is the food choices that you make, and we'll talk about that more in one of the last myths. But if you're hungry 5 times a day, you should eat healthy, unprocessed foods 5 times a day. If you're hungry 2 times a day, as long as you're meeting all your requirements and getting enough nutrients in, then you should only eat 2 times a day. But your body is far smarter than your doctor. And that is a very important lesson for you to recognize. And there's no way that I'm going to be able to give a blanket recommendation that will apply to all my patients. There's huge variability in what people experience after the surgery. And I can't make single recommendations that apply to all my patients. Rather, I work with them and try to figure out, is this an important factor for you or not? If straws cause pain every time you use them, you shouldn't use straws. If straws don't cause any discomfort whatsoever, go for it. The same thing applies to how often you eat. Myth number 7, you can't drink and eat at the same time. This is true in some patients, and I have had many, many people tell me that if they drink water after eating a meal, they will throw up. And again, it comes back to the fact that that blanket recommendations for all bariatric patients are unlikely to be true and appropriate. Rather, you have to kind of figure this out for yourself. And if you throw up when you drink after eating, then you should not be drinking after eating. But the vast majority of patients have no problems with this, and it is a difficult requirement. It is sometimes when you're eating, you get thirsty, and if you feel like you can't drink for an hour after you eat, well, that can be pretty tough for you. There's also, I see a lot of talk about water loading before surgery and all this kind of stuff. To me, that's just gamesmanship, and instead you should just try to eat well, eat a healthy diet, make good food choices, eat when you're hungry, don't eat when you're not, stop when you're full or satisfied, and you'll have a very good result and should lose all the weight that the surgery will allow. And then the final meal is protein first at every meal. And my issue with this is that although I believe this is probably a really good recommendation for the first 3 months after surgery, in the long run it does a disservice to our bariatric patients. Of all the complications, of all the problems that you can have after surgery, without question, the one that exceeds everything by a factor of probably 8 to 10 times is weight regain and a return to old habits. Malnutrition, severe vitamin deficiencies from not eating enough, are exceptionally rare. We do see iron deficiencies, I've mentioned in some of our other videos, after gastric bypass, or B12 deficiency after sleeve gastrectomy. But malnutrition after these surgeries is very, very uncommon, especially as it results to not eating enough nutrients. Weight regain is unfortunately way too common, anywhere from 15 to 25% depending on which of the studies you look at and how far out in the future you look. So when we talk about protein first at every meal, we're missing the single most important food that will help you to lose weight and keep it off for the rest of your life, and that's vegetables. So in the first 3 months after surgery, we do focus on protein first because at this point, patients are unlikely to be able to easily meet their 50 or 60 grams of protein that they need to take every day. And instead, so we focus on that. We use the protein shakes in this phase because I think that it's a really convenient and easy way to get a lot of protein. However, as you go out further, there's little to no chance that you're not going to eat enough protein every day. You don't need a ton of protein. That's not the secret to weight loss. The secret to weight loss is to eat unprocessed foods, especially since most of the time after surgery, we're not looking to lose additional weight. We're trying to prevent weight regain. And eating a largely unprocessed diet, fruits and vegetables, nuts, seeds, beans, all of these things will help prevent weight regain. And we should be eating vegetables first. In my practice, it's the first 3 months it's protein first, and then for the rest of your life, it's eat your vegetables first, eat your fruit first, eat your nuts first, eat your beans first. These are the foods that are going to prevent weight regain. These are also the foods that are going to provide tons and tons of nutrition for you. So I hope that was helpful in dispelling some common myths. If you're interested in learning more, you can subscribe to my YouTube channel. You can pick up a copy of my book on Amazon. The book is called A Pound of Cure. You can visit our Facebook page for the book at it's also called A Pound of Cure. And finally, if you're in southeastern Michigan and interested in coming in to see me for an appointment, either for bariatric surgery, for help after bariatric surgery, or even for help losing weight without surgery, you can contact my office at the phone number listed or through our website, www.drmatthewweiner.com. Thank you.